Okay, now you can stop sharing your slide, Jenny.
Yeah, I put it on. Did you see?
Yeah. So
okay.
Okay.
So Sandeep, slide টা এরকমই থাকবে নাকি?
Yeah, this is fine. I mean, it's like Jenny, is it so when we actually start the talk, I mean Jenny's talk, Jenny, is it full screen on your laptop or
on the other screen? So
yeah,
I'm going to try to, yeah. I mean, it's a full screen on my, it's with a note on my laptop, a full screen on the other monitor. So which one you see now?
We just see the slides. We don't see any notes.
Okay, thanks.
Yeah. So yeah, I mean, Dr. Hussain, I think this is fine.
Okay, thank you, Sandeep. So
okay.
Good evening, everybody. I heartily welcome all the participants who have joined our webinar titled Applying Advanced Analytics in Pharmaceutical Outcome Research. Broadly title of webinar is Machine Learning Artificial Intelligence in Pharmaceutical Sciences. Due to unavoidable reasons, our Honorable Vice Chancellor will not be able to join this program. So today we have with us Professor Pranabes Chakraborty. He is the Director of Pharmaceutical and Medical Science of Technology, Maulana Abul Kalam Azad University of Technology. And we have with us Dr. Sandipan Bhattacharjee. He is Associate Professor of Health Outcome Division, Department of College of Pharmacy in University of Texas at Austin, United States. And we have with us our eminent speaker today, Dr. Jenny Suan Jenny Losi Janak. She is an assistant professor in Department of Pharmaceutical Outcomes and Policy, University of Florida, United States. And I am Dr. C.M. Hussain, HOD, Head of the Department of Pharmaceutical Technology, Makaut, West Bengal, today moderator of this program. So artificial intelligence and machine learning, this is an emerging technology, definitely, and it's a subset of actually machine learning is a subset of AI that focuses on the narrow range of activities. It combines machine learning with the big data analytics and cloud computing, while machine learning is based on idea that machines should be able to learn and adapt through experiences. Artificial intelligence refer to the broader idea which machines can execute tasks smartly. So artificial intelligence applies machine learning and deep learning to solve actual problem in different sectors. So there are wide application of artificial intelligence and machine learning in health and pharmaceutical industry, like disease mapping, practical, proactive healthcare management, disease detection, diagnosis, decision making, predictive analysis to reduce the time, money, and also future prediction, also prevent some personalized medicine and precise medicine, drug abuse, drug discovery and manufacturing, clinical trial research, radiology and radiotherapy. Even it has also wide application in the smart electronic health record. And nowadays it is very much important in COVID crisis. Artificial intelligence will be much helpful for the epidemic outbreak. So without wasting much time, I would like to just introduce Dr. Sandipan Bhattacharjee. She is my beloved junior. Now he is Associate Professor of Health Outcome Divisions, College of Pharmacy, University of Texas at Austin, United States. I would like to request Dr. Sandipan Bhattacharjee to introduce our key speaker. I'm extremely sorry, I just skipped that. I would like to, before introducing Jenny, I would like to request, I beg your pardon, sir, I would like to request Professor Pranabes Chakraborty to deliver the keynote speech of this program. I'm sorry, sir, I beg your pardon.
Okay.
Yes, I skipped it.
Shubho Shanda, very good evening. Our warm, hearty welcome to Dr. Jenny from University of Florida. Dr. Sandipan Just now I came to know that he's our junior professional and junior Jadavpurian from Jadavpur University. My beloved Dr. C.M. Hussain, head of the Department of Pharmaceutical Technology in Makaut. And simultaneously, I am welcoming, hearty welcome to all the directors, our Honorable Vice Chancellor, conveying our warm and hearty wishes and regards to our Honorable Vice Chancellor, who is always enthusiastic about this type of seminars, webinars, so that our forthcoming generation can come to know about the most advanced studies and applications of this type of data analytics, artificial intelligence, and other matters which will enrich them for tomorrow's learning and application. I am conveying warm, hearty welcome to our Honorable Registrar, all the directors of the university, all the faculty members, scientists of the university, and the learned faculty members, honorable directors and principals of different colleges from India and abroad. Today, we are really privileged that we have got with us Dr. Jenny, who has enormous knowledge on these subjects of data analytics and machine learning, artificial intelligence in the advanced stage. You know, beforehand, we had arranged this type of seminar with the Senior Director Subroto Chakraborty from SIPLA, and today we'll be learning from Dr. Jenny and Dr. Sandipan, who they are working hard on this in USA. And with that, Jenny, what I have learned from Dr. Masoom, that Jenny has worked on these subjects, how the usefulness of this advanced studies. She not only studied, not only researched, but also she has applied this artificial intelligence, the concept of data analytics, all these things into reality. She will be telling us, she will throw new light to our students and our junior faculty members, and also the seniors who have not come across these advanced studies of data analytics and artificial intelligence, and how it is helping the pharmaceutical studies and the industries as well. Simultaneously, she'll be telling about the limitation of these concepts. I'll request my beloved students to listen and take notes of it so that they can be enriched, and tomorrow they can learn from Dr. Jenny, not only Dr. Jenny, in their own life, they can start learning about these concepts and can apply in the future in India. With this, I am again welcoming you all, and you stay with us, listen, learn, or apply to your own fields. Thank you. Thank you all. Good evening.
Thank you, sir. Thank you so much for your enriched
Thank you.
speech. Now, I would like to request Dr. Sandipan Bhattacharjee, a dynamic scientist, and he is currently Associate Professor of Health Outcome Division, College of Pharmacy, University of Still. I would request Sandy, would you please introduce Jenny?
Sure. First of all, thank you so much for inviting us and organizing this webinar. I'm sure that the folks who are listening in, the students and everyone listening in, will get a good idea about machine learning and artificial intelligence in the pharmaceutical sciences. And it's and again, to all the esteemed panelists, I would like to convey my best regards to all of you. And having said that, I mean, before I read about Jenny's all the different achievements, I just wanted to mention that she is a very close collaborator and a colleague of mine, and we have been working almost for the past 5.5, 6 years. She and I had an overlap of almost 3.5 years in University of Arizona before she moved to University of Florida. And now I have also moved to UT Austin. So we are at different places, but we have a lot of work that are going in together. So, and I learned a lot from her. She is great, in all this advanced analytics stuffs and all. So to just give you like a brief overview, because, she has done a lot, but to give a little bit overview about Dr. Lo-Saganik. So Dr. Lo-Saganik is a pharmacoepidemiologist and assistant professor in the Department of Pharmaceutical Outcomes and Policy at the University of Florida College of Pharmacy. She is also a core faculty member in the Center for Drug Evaluation and Safety at the University of Florida. Her research agenda focuses on improving drug safety, medication adherence, pain management, and treatment for substance use disorders. Dr. Lo-Saganik has extensive experience applying advanced predictive analytics, including machine learning and group-based trajectory modeling with large healthcare datasets. She has also served as a principal investigator and co-investigators on multiple federally and organization-funded grants using advanced predictive analytics. And currently, she is the co-PI for the R01 project funded by the National Institute of Drug Abuse, or NIDA, which is titled Using Machine Learning to Predict Problematic Opioid Use. And more recently, she is the PI of an R21 project funded by the National Institute of Aging, which the title of which is Developing a Real-Time Risk Prediction Tool to Identify Potentially Unsafe Concurrent Opioid and Benzodiazepine Use among older adults. And for that also she has applied one of the advanced technique, which is a group-based trajectory modeling. And in terms of service, she has, since 2015, she has been a member and co-chair of the Pharmacy Quality Alliance, or PQA, is work groups and quality metrics expert panel to develop and improve multiple quality measures such as opioid use. Now, having said all these things, I just would like to mention that I have an unforeseen conflict for which I have to sign off within the next 15 minutes or so, because I have a meeting with SCORE. But I am sure that you guys will, have a great time listening to Dr. Lo-Saganik and having some interactions. So I wish you all the best, and thank you, Dr. Lo-Saganik, for taking the time from your busy schedule to talk to everyone. Really appreciate it, and the floor is all yours.
Thank you. Thank you, Sandy. I really appreciate, and it's a great honor and a pleasure for me to present this work to you. And I'm really excited. And although I wish I can be in India in person, but right now, given the COVID season, this is the best solution. And nice to meet you all. And can everybody hear me? Okay. Yeah. Okay. Good. So let's get started. I know it's it's in the evening in India, so I hope this won't put you to sleep too fast. So let's start with, can you see my screen, right? Yeah, okay. Yes, okay, great, thank you. Okay, so Today I'm going to talk about given a more high-level introduction on applying advanced predictive analytics in pharmaceutical outcome research. And again, I'm Jenny Lo together from.
Ma'am, PPT is not staying.
I don't see your slides on the screen.
Please share the screen, ma'am.
Oh, you couldn't see my slide?
No, ma'am. Please reshare it, ma'am.
Okay, hold on a second. Let me redo it again, okay? Can you see my slide?
Yeah, thank you.
Okay, sorry about that. Okay. So again, today I'm going to focus on given a more high-level introduction on applying advanced analytic in pharmaceutical outcome research. And let me just pull out the chat box in the other screen so I can see your question. And hopefully I'll try my best to answer your question in a real-time manner, but sometimes I need to also make sure we can cover the content of the slide. And maybe I'll save some time if I don't answer, I didn't see your question in the chat box, maybe feel free to ask again at the final Q&A session. Okay, let me see. Okay, so just a quick reminder, some of the parts of the presentation results are in the process of the intellectual patenting by the University of Florida. So if you are interested to use any of this results, please contact me. Just want to make sure we don't have a violation on the patenting process. Okay, so today's outline, I usually like to start with a presentation introducing myself, and then I'm going to give an overview on the artificial intelligence and the machine learning. And if I understand correctly, our audience come from a very diverse background. So I want to disclose that, this is only a 1-hour presentation or a 1-hour talk. So I cannot really I need to take care of the audience with a different background doesn't have any knowledge on the machine learning, and from maybe you have some hands-on skills on the machine learning technique. So even for like a 2-day seminar or workshop, it's hard to cover the machine learning thoroughly and teaching the programming. Don't even mention about this 1-hour presentation. So overall, I'm introducing in a more like a high-level concept and what's the application. But if you're interested in more in the deep, like a Python or some language, then there are other more advanced workshops that I offer in other workshop or other graduate programs. So, but that's not today's focus. So I just want to disclose that first. And the omission is intentional. So it's it's just because the audience background. And I'm going to talk a little, give a very brief, because as a pharmacy, most of you have a pharmacy-related background, and what's the role of machine learning and AI in pharmaceutical science. And I want to show you a few examples from the work from my research team, and then what's the challenge and the direction you are going to expect in the machine learning and the AI area. And then open for the final Q&A. Okay, so about me is I received my pharmacist training from National Taiwan University. I'm from Taiwan. So you probably can tell from the year, guess my age. So I'm getting older. And I received my master in clinical pharmacy in Taiwan too. And in 2006, I want to bridge the research and the clinical practice together. So I went to US to pursue my PhD in epidemiology at the University of Pittsburgh in 2006. During my PhD program, I decided to pursue another master in biostatistics degree. So that's how, but I didn't finish my PhD until 2013. So it took me a long time, 7 years, to finish both master and the PhD, and I can tell you the reason why. And after I graduated from the PhD program, I did a postdoc at the Center for Pharmaceutical Policy and Prescribing, also at the University of Pittsburgh, before I started my faculty appointment at the University of Arizona. And thank you for Sandy Penn introduced me. And as he say, we have overlapping the time when we were in the Arizona, and he is a good colleague and a great friend to me, and we still continue working together. And I talk about Arizona. I don't know how many of you visit Arizona before, but what I love about Arizona is the desert scene is just so astonishing. It's just so amazing. So I don't know if you have this type of you probably doesn't have this cactus in India where you live. This is what we call saguaro. And I want to, maybe someone can guess, you see the saguaro is a giant cactus, and usually when they grow up the first arm, and it takes some time. This is like doesn't have arm, and this has many arms. So does anybody want to take a guess how many years to take the first, the saguaro to grow the first arm? Maybe somebody can type in the chat. I just want to have a little bit of interaction question, so make sure, to see if everybody is paying attention. So can someone try to get 1, 10, 5? Great, awesome. Anything? Getting more. This is too little. No, more than 10, more than 10, more than 10, 20, more than 20. Very good. Okay, so 25. Okay, let me tell you, this is a very slow growing plant. So I saw 120 years. That's too long. It takes 75 years to grow the first arm, on average, 75 years. And then the rest of them, it depends on the weather. So this, 75 years to grow the first arm. So it takes very long, but it's a beautiful, very cute plant, and I really enjoy the time there. Not for every arm takes 75 years. So first arm takes 75 years, but the rest of it can take from 10 to 30. It's different. Okay, so the reason why it took me so long to study PhD is because my first two sons was born during my PhD program, and the third son was born during my postdoc. And finally, we have our first daughter and the last child in our family last year, and she is just turned 1, and so I think that's good. I'm done on time. And last year I went to a conference and I brought the baby with me because she was little, and I got so many people come to talk to me, but they are not interested in talking to me. Actually, they want to see the baby. So so if you want to have a connection in the conference, the best way is to bring your baby. Then you will get so popular, I guarantee you. And if you don't have a baby, maybe you can borrow one from someone, and you will get a lot of attention. So that's my family. And my research focused on traditional pharmacoepidemiology and drug safety. And also a lot of my focus also to evaluate the medication adherence and health outcome, and also how can I improve the measures of the medication adherence. And recently I did a lot of the pain management and substance use disorder given the opioid epidemic or opioid crisis in the US. I also, as you can see, I also do a lot of the advanced predictive analytics to improve the health outcome and quality. And finally, I also do health service research and to evaluate health disparity and also policy impact, and also program evaluation. So in terms of the technique-wise, my research can have 3 aspects. One is applying machine learning. And that's our today's focus. But I also do a lot of group-based trajectory modeling, and to evaluate the dynamic, visualize the dynamic utilization of the medication use. And the third one is a spatial analysis, but I'm not going to focus on the second and the third today. I'm only going to focus on the machine learning part. Okay, so when people talking about the AI and application in healthcare, sometimes if you don't know this area, it can get a little bit intimidating. But actually, machine learning and AI application are just in our backyard. I mean, it's from the email fraud detection, and also in Amazon, in US, if you are Amazon user, Amazon even have a program like a ship the product before you buy the product. And that's also part of, also is using AI and machine learning technique to see what are you going to buy from your previous purchasing history. And the Netflix several years ago, they have a competition to see which team can best predict what the customer, what kind of film, what kind of movie customer like. And guess what? The champion was the team using machine learning and to identify what kind of movie the audience like. So that Netflix made a lot of the in-house film based on this type of algorithm. And also, if you have iPhone, sometimes I press wrong, and Siri will say, "What can I help you? I don't understand what you're talking." It's also part of the AI and the machine learning. And in US, we have a Uber driverless car. So it's also based on AI machine learning technique. And if you know there's some chase game or some gaming technique, it's also you try to compare the human compete with the computer, like IBM Watson is also a type of machine learning. So AI and machine learning are really trendy topics in the healthcare now. And it just has you can see this is from the value in health in the outcome field that we have. From the journal or from the vendor, like a lot of consulting company, a lot of pharmaceutical company, they are invest a lot of the efforts into AI machine learning technique because it's really hot right now. And when you apply for the job, if you have an AI and machine learning technique, a lot of companies are also would like to recruit you because that is also one of the very competitive ability they are looking for too. So why AI and machine learning gets so much attention? Because one of the biggest reasons is that we are in the era of the big data. When I say big data, it's including can explain with a 6V, it's including volume, it's a large amount of the data. And it's including the variety, different type of the data. As you can see in this graph, there's from the provider, hospital EHR, or your iPhone, like you track your vital sign, and also velocity. When you have such big amount of data, it's going to influence the speed. And the veracity is the reliability of the data. I mean, when you do anything with this data, you need to also concern about how reliable they are. And also the variability approach, how are you going to handle them? When you handle the imaging data, when you handle the traditional healthcare data, you need to use a different technique. And at the value, what are you going to do with this? Are you going to do this for business or in the healthcare system? The challenge, derived from this type of big data, as you can see from the 6V, it's talking about the storage and transfer. How do you combine them together? Can you visualize them? And how do you do the analysis? And finally, very important, how do you interpret the data? And the AI and machine learning can be one of the solutions to speed out the process. And I'm sorry, as you can see in this graph, we have the different size. And right now, all the U.S. academic research library is about 1,000 petabytes. But the highest is a yottabyte, 1024 times. So you can see this is the highest capacity right now in the U.S. So as you can see, yes, we are entering in the realm of the big data, and that's why AI and machine learning might be one of the solutions to help us to streamline the process. A lot of people using AI and machine learning exchangeably, those two terms, but it may sound hot and right now in healthcare, but AI and machine learning are not a new concept. And the idea actually already started back in the 1950s. So the AI refers to, AI is more like a broad box. It's including any technique enabling the computer to mimic the human behavior in some way. And the machine learning is a subset of the AI. It consists the techniques enabling the computer to figure out the things from the data and deliver, potentially be able to integrate in the future AI applications. So as you can see, and some people right now, you can hear so hot topic right now as the artificial neural network or deep neural network. And one of the audience also asked about like eye track movement, or you see the Google technique to see the retinopathy, like to diagnose the retinopathy, all those type of things. I think a lot of them, they are applying a more neural network or deep learning type of technique because it can have greatly improved the technique. I saw one question, how the big data has a security feature. So that's another great question. I'm going to say that at the end of my question, one of my slides to discuss about it. And please bear with me for some time. So what is machine learning? As a human, we learn from the experience. But you think about if you have a robot or any toy, and you have a robot, you want the robot follow your instructions. And in the healthcare data, you want to learn from the historical healthcare data or the historical data to see what kind of, can you turn into the useful knowledge and or useful pattern to inform or better guide the clinical care. And we are all probably, if you are have a background in biostatistical statistics, and sometimes you might find some AI or data scientists expert when they're talking about things, and it's a little bit confusing, but actually they are referred to the same thing. So in the statistics, sometimes in the formula, linear regression, you have X. And in the statistics, you call them independent variables or predictors or covariants. But in AI, you might heard the data scientists call them how many inputs you have, how many features you have, how many attributes you have. And in the statistic, you will call Y as a dependent variable or outcome or response. But in AI or machine learning, you may call them output or target. And so sometimes in each data point in statistics, we call data points or sample. But in AI or machine learning, you might call them example or training data. And when you fit any regression in statistics, you call them model fitting. But in AI and machine learning, we just call them machine learning techniques. So there are different terms, but actually they are referred to the similar stuff. So there are several major types of the machine learning that I want you to know. The first one is we call unsupervised learning. Unsupervised learning usually refers to non-labeled data. What do I mean with the non-labeled data? I mean, usually you only have a tons of X. You don't know why. So usually this type of data, you don't have outcome. You don't know what's happened. You just have a bunch of the X. And you want to be able to group them and also identify the pattern of them. To just grouping them to the cluster. So the technique commonly used in the unsupervised machine learning include a clustering and a dimensional reduction. So when dimensional reduction, that's usually commonly used technique in the pharmacogenomic data, because, excuse me, in the pharmacogenomic or genomic study, you might have only very few participants, but with thousands or hundreds of genes information or SNP information. So in that situation, traditional statistic methods are not going to work well. So you need to reduce the dimensional. And the pharmacogenomics means like you want to do the precision medicine, and like sometimes if you with a certain specific genetic, you might have a different response to the medication. So that is it's more in the pharmacogenomic field. Thank you for the question. And the second one is the supervised learning. Supervised learning, also we use the label data. We use the label data. The label data refers that you have output, you have a Y, you have your outcome. For example, you know if this patient die or alive, or if you know this patient have a heart attack or doesn't have a heart attack. So when you know the outcome of this patient, what happened to this patient, we call label data. And any technique identify the outcome of what's going to happen for this patient is called supervised learning. Commonly, technique for supervised learning has two categories. The first category, if your outcome is categorical variable. When I say categorical variable, that refers die or not die, and had a heart attack or doesn't have heart attack. Maybe what else? Have an overdose and it doesn't have overdose. This type we call it the classification problem. So there are some techniques specialized for the classification problem. And there's also regression problem is using for continuous variable. So let me give you an example. The common continuous variable could be healthcare expenditure, how much money it costs. So if this type of the issue is a continuous variable, you will need to use a regression type approach in the machine learning. And the third type is a reinforced learning. That is commonly used for rewards and recommendation, feedback, and the algorithm on how to react certain environments. It's very commonly used in gaming. So they based on your response, or the GPS navigation. So I'm really notorious getting lost. So if I get lost, what the GPS will do? You are going to see on your phone or on your GPS say rerouting. So based on what you are doing, then the algorithm know how to act back in the based on what you do. So that is more reinforced learning. So there's another category, semi-supervised learning, because some people you might not know if they die or not. So that is more like a semi-supervised learning. So today in our healthcare field, health outcome field, I would say the most commonly technique we are using focused on the classification problem. So that will be our focus today too. Because I'm talking about health outcome field is more on the post-marketing research. So example, you might ask, among the machine learning technique, how do I know which are the machine learning technique and which one to use? And if you want to identify patterning, there's a cluster technique, like for example, like a k-nearest neighbor. There's also like try to identify the important variable from the high dimensional data as a variable selection is a lasso type of technique. And you can also using decision tree has a more flexible the assumption. So in order to classify patient in the more same risk group. And random forest is an advanced decision tree. It's running the like thousands or hundreds trees in parallel at the same time, and in order to improve and stabilize the prediction performance. And that is the random forest. And this is and there's also a support vector machine using the hyperplane. So there are different types of the machine learning techniques, and they are all have an advantage and a disadvantage, and depends on what type of question you have. And the neural network is really hot right now because a lot of the very complicated work like patterning or imaging and the imaging detection is also a type of neural network. So what is lasso? Lasso is logistic regression, and lasso is more advanced in terms of like a logistic regression or linear regression. It penalizes those factors are not important, so you can kick out those unimportant factors and in a more efficient way. So there's also like we call super learner. You run the algorithm using all different methods, and then you combine all the algorithm together. We call super learner. And sometimes it improves the prediction a little bit, but depends on the question. Sometimes you might see not a big improvement. So depends on your question. Sometimes a lot of time we have run many different techniques in order to achieve the best performance. So random forest is the ensembling method, like it's a advanced version of the decision tree. So you can see each one is represented each decision tree. But random forest is randomly running using the different predictor, like randomly pull from the box and then and around like 100 tree, 1,000 tree at the same time, and in order to reduce the misclassification error. So when I answer the questions, and I try to be brief because I cannot go too detailed because they're too technical. So if you are interested, if I don't, my answer is not satisfying you, please feel free to send me a follow-up email or follow-up at the end. Thank you. The hot topic, I say, it's like a deep learning, imaging diagnosis, natural language processing. Natural language processing has been used a lot in the extract the clinical note, or like in social media, you type something, and for example, maybe I say ice cream, but the other person just say icy, and the other person may say cream, and they try to identify some rule-based algorithm to collect the similar term together. For example, you might say heart attack. The other person say myocardial infarction, but they are referring to the same thing. So if you want to extract useful information from the clinical notes, that is type of the natural language processing. And also cognitive computing, like a Siri or super learner, or a lot of the like one student asked, I track those type of things. Those are more like a deep learning side and a more higher end, more complex technique. So many of you have a pharmaceutical background, and so I want to talk about in the pharmaceutical pharmaceutical science. When you develop a drug, there's like a preclinical study, right? And there's also the pre-approval study. Means preclinical study is before you use it to human, and then pre-approved clinical study is like for getting drug approved by the FDA. And there's a post-marketing part is after the drug get on the market. And like for example, in our department, at the University of Florida, we have 5 major departments. For example, I'm in the pharmaceutical outcome and policy, which is POP. But there's also medicinal chemistry, pharmacodynamic, and pharmaceutics, or pharmacotherapy and the translational science. But machine learning actually can fit in the different area. For example, in the medicinal chemistry, you can apply machine learning technique to identify the compound, create a compound library, and to specialize and identify the roles of the target in the disease. Or you can identify drug-target interactions, or using AI and machine learning in the structure activity prediction, and like biosimulation, and also how do you select the right clinical trial participant, and the pharmacogenomic, as I said before. And in my field, it's more like a more post-marketing application. Like can we use this to develop the more identified drug response and the risk prediction, and also the clinical decision tools. So these are some examples. For example, the published in the Natural Chemistry Biology is an active role of machine learning in drug development. And also the drug repurposing for cancer using the natural language processing tool to identify the new indication for the old drug or new mechanism for old drug. And you can also use a machine learning data mining technique to identify adverse drug events from the post-marketing data or active surveillance data. And you can also apply machine learning to identify which gene, which genomic characteristic is the most relevant to certain situations. And these are just some you use, in our field, we use a lot for the risk prediction. So like predicting the mortality after the certain disease, like in this case, sepsis. And also you can also use machine learning to improve the causal like a bias adjustments or confounding adjustment in the propensity score estimation. So these are, I just want to show you, machine learning is a trending topic and also very going to be a huge trend in the pharmaceutical science, no matter which area you are in now. So as I say, in my field, we use a lot of the prediction using machine learning, using machine learning for risk prediction. So what is the risk prediction trying to do? So you have no matter what kind of data you have, either it's some collecting from your iPhone or from the healthcare data, you try to learn from the past and try to understand why did it happen. And you try to do the pattern detection or automated discovery. And then you want to apply the certain machine learning technique to do to know what will happen, do some risk prediction. And then once you develop the prediction algorithm, you want to know whether there's a real time. Can you apply this algorithm in healthcare system in the real time in order to improve the process and to change the future or to avoid some adverse outcome? So what can you do with a machine learning algorithm to change the outcome for the patient care or clinical care? So that is when you try to automatize, make it the process automatic and or in the human behavior, that is going to a more AI part. So you might ask, when do you need to use machine learning for prediction? So some people, when the machine learning and AI is getting so hot topic, that doesn't mean traditional statistical methods are useless. A lot of time, I have a graduate student come to me and then say, I want to use machine learning in this research. And I always ask them why. Because sometimes you can just use a simple technique and you can get the same answer. Machine learning doesn't always necessarily helpful in some situation. So when will machine learning be helpful? It is when when you have a problem or issues with using traditional analytical data. Usually that happens when your data are highly dimensional, means that you have a very few participants, and then the genetic data is like 1,000. So each patient has thousands of data. That is a high dimensional data. You need to reduce the dimensionality. And if your data are all highly correlated, we all know in a lot of the statistical approach, when the variables are highly correlated, sometimes you are going to encounter the multicollinearity problem. So machine learning sometimes doesn't require a lot of the restricted assumptions, and traditional statistical methods also have some limitation to handle the complex interactions. But I want to say, usually, so the goal is that if your problem, if you really think there's a complex interaction or some hidden patterns, and that cannot using by the very simple logical rules, then machine learning might have a role. And machine learning is good at improve the accuracy. But a lot of the machine learning problem, the technique like a deep learning, some people call it a black box because you couldn't really see what's going on. Like now, like a logistic regression, you know each variable's odds ratio. Sometimes it's only give you some prediction score. So if your goal, accuracy is more important than the interpretability, and then maybe machine learning is a better solution in your case. But at the end, I still want to say machine learning and the traditional statistic methods the goal is for they are complementary to each other. You should use them both, and they are supposed to be strong together, not like against each other. So let me ask you, why do you want to identify or predict a high-risk individual or area? Can somebody think about any reason you want to identify or create some algorithm for predicting the high-risk individuals and areas? Why not just, let's say I'm interested in identify diabetes patient. Why not just target all the diabetes patients in India? Drug safety, that's good. To identify outliers for security purpose, yeah. And anything else? Thank you for response. Okay, poor responder, that's good. ADR reporting, that's great. Okay, so let's say you have a diabetes patient, or you want to identify who is going to have a heart attack. Prevention of disease, that's all very good answer, thank you. So this person, the blue one, is the one at high risk. How do you identify this person without screening everybody in India? How do we do that? In India, can you try to screen all the Indians and then find out who is going to have a heart attack or not? So one of the big issue is that you have very limited time and the resources. And one is time, one is money. First of all, you are not going to have enough money to screen everybody in India. Second, it's going to take years and years. And is that sufficient? Probably not. So you really want to know who is at high risk. You want to know, like I also say, 6W. It's like, okay, why this happened to this patient? I mean, why this patient has a heart attack? Who is this patient? I mean, first is you identify who is this patient, why does this patient happen, and what's happened to them? How did this patient get into the heart attack? What kind of the history or characteristic leading them to have a heart attack? And when will this happen and where? So we believe, when you study the disease or any disease or condition or pharmacology, I mean, usually we always joke around, no patient is going to follow the textbook because in the real world, the disease and the patterns are very complicated, right? So it's never follow the textbook a lot of time. So one size doesn't fit for all. So maybe machine learning can help you to more tailor your treatment. So that is also why do you want to identify the high-risk individual or area to better allocate your resource and a better, more efficiently, because thinking about the business field. So are you going to do the marketing to everybody on the street, or you are going to observe who is going to buy this product or not? If you can identify a person who is more likely to buy this product, isn't that more saving your time, right? So we want to apply the similar concept to the healthcare field, in business to the healthcare field. So I want to, as a pharmacoepidemiologist and also a biostatistician and overlapping with the data science area, I really want to emphasize a lot of the article that data scientists publish sometimes were criticized by the epidemiologists because when you want to do any prediction analysis, I will highly recommend you to follow the guideline. And there is a tripart guideline, and it's I think you can get it from the BMJ or Annals Internal Medicine. It's some checklist you should follow if you are interested in doing any machine learning prediction. So there are two types of study in the TRIPAD guideline. One is a diagnostic problem. One is a prognostic problem. What do I mean for the diagnosis and the prognosis problem? The main difference is about the concept of time. And let me show you. Diagnosis variable, multivariable modeling is, let's say right now it's COVID. So let's say you have a fever and you develop some symptom. I want to know, given your symptom and the sign and the nasal swab, do you really have at this time point, do you have a COVID or not? This is called the diagnosis problem. It's a cross-sectional relationship. You want to know it now when you measure those predictors at the same time. The other problem is a prognostic problem, is you go back to their back history to see, oh, do they use the opioid prescription? Do they use any pain medication? And or identify other factors in the past. And using the past information to predict, is this person going to have a heart attack in the next year? Is this person going to have a drug overdose in the next 3 months? So when you have a time element with a longitudinal relation follow-up, this is the type of the prognostic problem. So any of the machine learning prediction, you are going to see there's a different type of way to do it, but usually it's involved, you need to do some random split the data in order, you train the data in one, you train the model in some subset of the data, and then you do the validation in the other subset to make sure your algorithm is good and not overfitting it. When I say overfitting it, you try to improve the accuracy, but actually you overdo it, and so it's only used in this subset. It doesn't apply to any real world data. So either you need to do the validation or testing. Some people call testing or validation, but you need to do some type of validation to avoid model fitting and evaluate the model performance. So why I want to emphasize the TRIPAD, try to adhere TRIPAD guideline and complete the checklist is really essential if you are interested in publish this type of study, because when I encourage you to do that, that means right now we don't do a good job. So, before the TRIPAD, right away TRIPAD apply, you can see, only less than 50% of the essential TRIPAD articles were not fully addressed. And this is before the TRIPAD introduced. But after TRIPAD introduced, does anyone care? Not really, because you can still see almost only less than 30% they follow the TRIPAD guideline. So I want to say, if you want to do the study right, and I will encourage you to follow this checklist and to make sure people won't criticize you. Oh, this is a piece of the not thoroughly designed study, so not fully reported study. So be careful how you do it. So then the fourth section, I want to give you examples from my research team. So this is the article we published, my team published in the JAMA Open last year. And a lot of my work is given the U.S. opioid crisis, we got funding from the National Institute of Health to use the machine learning to predict the risk of the opioid overdose in Medicare. And this is funded by National Institute of Drug Abuse and also part of my Pharma Foundation award. And why do we want to do this? Because the gap in the research is a lot of the study, even though they say they are predicting the opioid overdose or opioid use disorder, they focus on identifying the risk factors. And however, when you say a factor is a risk factor, a strong risk factor, it does not always mean this factor is a strong predictor. There's a well-known New England Journal article showing a strong risk factor has a 4 or 7 times of odds ratio, but only improve the prediction very, very little. So strong predictor are not equal to the strong risk factor is not necessarily a strong predictor. And most of the study they have a suboptimal prediction performance. And some of the study design use case control study design, and it's very hard to apply to the real world data. And also some of them use a traditional statistical methods. So statistics in the, thinking about addiction and drug abuse type of research, you probably can imagine there's a lot of complex interaction between the mental health and the drug use pattern, many complex issues. So maybe we thought machine learning can better help us to more accurately identify the people at risk of the drug overdose at a real-time setting. So our objective is the current approach to identify individuals at a high risk of the opioid overdose target many patients are not truly at high risk. So we want to know, can machine learning be more accurately predict the opioid overdose risk among fee-for-service Medicare beneficiary? This is a prognostic study that I introduced earlier, and using with a retrospective cohort study design, using a 5% national sample from the Medicare population in the U.S. So we have over 560,000 fee-for-service non-cancer beneficiaries with at least one opioid prescription. So again, I say in the tripart, they encourage you to do the validation. So we do the sample splitting method. So we split the sample into 3 sets. One is called training set, one is called testing set, and one is called validation set. The reason why we use a 3 set is some technique like deep learning. They use the testing information to refine the prediction algorithm. So we set this validation set aside, so we don't touch this part, and until we identify the best algorithm. Then we put the best algorithm in the validation set to see what's the prediction performance. So we included over 260 potential predictors, and we measure them every 3 months. So the index date is their first opioid prescription we ever can capture in the history. So this is the index day for the opioid prescription. After this point, and before this point, we create a 3-month window, dynamic 3-month window. So we updated all the information continuously until the end of the study year, or the patient, we couldn't die, or we disenroll from the health plan. And we always use for example, we use the first 3 months predictor information to predict, is this patient going to have opioid overdose in the second 3 months? And we use the second 3 month information to predict, is this patient going to have the opioid overdose risk in the third 3 months? So it's try to maintain the temporal association in the causality evaluation. And we use 5 machine learning technique in this study, and we use a different prediction performance measurement to evaluate the outcome. Thank you. And so the primary outcome is the opioid overdose in the subsequent 3 months. So how do we identify opioid overdose? We use the diagnosis code from the inpatient hospitalization stay or emergency department setting in the 3-month window. And using the ICD-9 and ICD-10 code. So as I say, I already explained the data study design. We always use the prior 3-month information to predict the outcome in the next 3 months. And the information is dynamically updated every 3 months. So we including the different predictors, over 268, and including the social demographics and the health status and the healthcare services, and the patterns of the opioid use and other important medications, and the provider level factors, like for example, provider, who is the person prescribed this medication, the gender, specialty, and what's the patient, this provider opioid prescribing volume. And we also link to some public available data on the regional and the access to care information. So including like area deprivation index and county health ranking to capture some social economic status or the poverty level. So we use a different 5 machine learning approach, including the multivariate logistic regression, and also LASSO type of it's a penalized logistic regression. It's a more advanced logistic regression if you think about that way in a brief explanation. And we use some tree-based approach, which is a random forest. It's a grow the multiple decision tree at the same time. And a gradient boosting machine is also type of the tree structure approach, but it's different from the random forest growing the multiple tree at the same time. The gradient boosting machine is improve the algorithm by the small tree, very small tree, and based on the previous tree to improve the next tree's performance, refine the algorithm in the next tree. So it's a sequential like. And a deep learning is a neural network type of the definition. So how do you evaluate the prediction performance? When you have a classification type of problem, I want to say there's we call a confusion matrix, because you are going to have a predicted category and an actual category. So actual category is does the patient has a real opioid overdose or not? And the patient does not have an opioid overdose or not. And there's a true positive and also true negative. And I'm sorry, how much time I left? I just want to be make sure I be respectful. Do I have
Jenny, you can
Yeah.
you can continue. Okay.
Okay. Thank you.
As much as you need time, it's no problem.
Okay.
Jenny.
Okay. Thank you. Okay, I'll try to finish save the next 15 minutes for the discussion. So, you have true categories. They have opioid overdose, and then you have did you predict them have an opioid overdose? This is the accurate one. We call true positive, and there's also true negative, and there's a false positive is when they don't have opioid overdose, you say they have opioid overdose. And the false negative is that when they have an opioid overdose, you say they don't have opioid overdose. Okay, so there's a different type of, if you are familiar in the epi term, and the sensitivity, specificity, and the positive predictive value, different type of measure can capture. So I would say that you can go to my appendix and I summarize this measure, what's their definition. So when your outcomes are rare, it is recommended to use some of the a number needed to evaluate or estimate positive alert rate in order to for the clinical utility, because C statistics not going to be C statistics won't be informative or can be misleading. So this is just an example. I'm going to help my students understand the calculation, but I'm not going to focus on this. And so when you evaluate the prediction performance, there's a two component, important component you want to evaluate. One is called discrimination, and one is called calibration. What do I mean by discrimination? Discrimination refers to the extent to which patient predicted as a high risk really shows they have a higher outcome rate compared to those predicted as a low risk. The common statistic we use in the clinical care is a C statistic. 0.5 means no better than just flip a coin, no better than by chance. The higher close to 1 means better. Over 0.8 means very good. It's trying to maximize the true positive and minimize the false positive rate. However, C statistic, like I say, C statistic or AUC under the ROC curve is not informative when predicting an outcome with the instance or prevalence less than 2%. So you need to use a more informative of clinical utility, like a PPV, positive predictive value, number need to evaluate, positive alert rate. So if you are interested, you can go to this article, why C statistics is not informative when you evaluate early warning, and rare outcome, when you have a rare outcome, it's not informative. So the other component you want to evaluate is the calibration of your performance. The calibration means the extent of those who predict the risk of the outcome agree with the observed risk. In other words, the rates you predict them as a high risk, they are also show they have a higher actual observed risk. I'm going to show you how the risk stratification one. You can either do the calibration curve on their probability. The closer to this diagonal one means it's better, or you can do the risk stratification to get some sense. So again, I say opioid overdose is a very important public health outcome, but it's a rare outcome. In Medicare, you can see it's a 6 out of the 10,000 patients during any time of study period. So we evaluate not only C statistics, but we also try to acknowledge C statistics not informative enough when the outcome is rare. So we also reported a number need to evaluate estimated positive alerts and other risk stratification strategy. So when you try to stratify patients into high risk, medium risk, or low risk, or you can have a 10 different types of risk group, but which cut point you want to use, it's always a question. But it really depends on who is going to use it. If you are the health plan, or if you are the hospital healthcare system, you can decide which cut point you use based on your resource and based on your the program, or what kind of program you have. So I'm going to show you an example. We use a 95 percentile, the risk score from the training sample to, if anything, the score above that point, we consider them as high risk. Or you can use the Uden index type of approach to identify the balance, sensitivity, and specificity. The problem with the prediction is that when you increase the sensitivity, you kind of reduce the specificity. It's like a balloon effect. So you squeeze this end and the other end getting bigger. So you want to have a balance. So Uden index is type of approach to identify the balance, sensitivity, and specificity. Okay, here is our outcome. So this is C statistics, and as you can see, the deep learning and the gradient boosting machine has the highest C statistics, and it's outperformed other traditional, other machine learning methods, and the C statistic can be 0.91. So I say as a rare outcome, you want to use a number need to evaluate, or like PPV or positive alert, in order to be more informative to the clinical utility. But how do I interpret this graph? So let's see, the x-axis is a sensitivity, and the y is a number need to evaluate. That means if you want to have a 90% sensitivity, which means you want to target 90% of the actual overdose, and how many people you need to screen in order to identify one opioid overdose. And for the deep learning, it's 525 people in order to identify one. And the gradient boosting machine approach is 631. You might say, oh, this is a lot. But if you go to look at the breast cancer mammography screening, depends on the population you do. Sometimes it can go over 1,000. So number need to evaluate, the concept is like a number need to treat or number need to harm in the clinical study. The less is better. And the positive alerts per 100 patients is, again, you want to target 90% of the actual overdose. And then you can, how many positive, if you use this algorithm, how many people you are going to get positive alert in your clinical system. Let's say hospital, you are the doctor, and how many you are going to get positive alert, say this patient might have an opioid overdose in the next 3 months. You use the deep learning, it's 29 people, GBM is 28 people. So the lower is better. Thinking about, if it's over than 50, then that means every 2 patients come to see you. You are seeing every 2 patients, you are going to get 1 out of 2 has a positive alert. So if you get a 100, that's every 100, all the patients you see, you are going to get a positive alert. Then this alert system is useless or not that useful. So this is a type how to make your prediction algorithm more the clinician can understand. Okay, so and I say the next step is that we do the risk stratification. So we do the risk stratification. Let's say that in this example, we use a top 5 percentile from the training data of the risk score. Of the risk score in the training data set to consider anything above that, we consider them in the high risk. And the low risk group is that we use the Uden index for the balance sensitivity and the specificity score. And anything below that, we consider them as a low risk. Anything in between, we consider them as a medium risk. So let me show you this, how to do this. How to interpret this graph. The y-axis is the actual overdose. So we have a 3 risk group. The gray line means the overall baseline actual overdose rate. This is a every 3 month interval, so it's a 0.05%. So that means if you don't have a prediction algorithm, you just grab anybody on the street in India, and what's your chance you are going to identify one overdose? The rate is 0.5%. So when you create any algorithm, you want to be better than this, right? So in this, our prediction algorithm can identify 76% as a low risk, and the low risk really lower than this line, which is good, which is what we want to see. But look at the high risk group. It's more than 10 times higher than this baseline rate. That means you can be more efficiently if you target this group, which is 5%, then you can capture 62% of the people with the actual overdose. And the number need to evaluate, if you only target this group as a high risk group, the number need to evaluate is lower from 525 to 174. And the positive alert can be reduced to 6 per 100 patients. And but medium risk group is kind of like a challenging part. Unless you have a lot of resources, it can capture additional 29% of the people with actual overdose. But if this is cost efficient, it's debatable. And the low risk group actually it's you almost nobody has it, and you are going to waste a lot of money and effort if it's you pretty much target everybody. So just thinking about how do you want to approach depends on the user. And as I said, deep learning sometimes can be a black box, and you don't really know what's inside there. So you can we use the gradient boosting machine can help us to understand what are the important predictors, because the gradient boosting machine has a similar performance. So as you can see, these are the top 50 important predictors. The first one is the total morphine equivalent dose. And the second is the history of any substance use disorder or alcohol use disorder. But I want to emphasize, as an epidemiologist, and some people like say, oh, this patient has a high morphine equivalent dose, and then we need to reduce it. But I want to emphasize, you need to be very careful to interpreting individual predictor alone. It really need to be done with the coaches, because all these factors contribute in prediction. It's like a very complex interaction, complex relationship. You cannot just take one out and then I'm going to target on this, but the other factor also contribute too. So be careful. I think when you use machine learning prediction algorithm, it's the risk score is the summary in consider all these factors. Okay, so we also compare the change, our algorithm with the standard currently practice used by the Center of the Medicare and Medicaid Service in US. And if we use their rule over 1 year, they capture about 30%. But in our algorithm, if we use a top 5 percentile as a high risk, we actually can capture 90%. So this is a great improvement. So machine learning approach outperforms traditional approach to predict the opioid risk among the fee-for-service Medicare beneficiary. And we have over 250 features. And we take into account the complex interaction and the hidden relationship. And the deep learning and the gradient boosting machine perform the best. And our prediction tool may help the stakeholder or healthcare system to more accurately identify the high-risk individuals and better allocate the resource for target intervention. Low-risk group, you can rule out the low-risk group almost almost no overdose occur in this group. And the high risk you can capture, depends on the threshold you use, you can capture 62% to 75% of the opioid overdose episode. And for the medium risk, I mean, it really depends on the resource you have. It might not be that cost efficient, but it can help you capture additional 10% to 30% of the opioid overdose episode. Like all the study, we have a limitation because this is the administrative claims data. So patient obtaining opioids from the non-medical setting, we won't be able to capture them. We are not able to know if the patient really consumed their opioid prescription or not, or just give it to other people. And we also don't know if the overdose occur outside the medical setting, and those are not captured. We won't be able to identify them. We don't have the lab result in the claims data, and also important behavior information that might be relevant to the substance use disorder. And maybe our algorithm is not generalizable to other populations. So the other second study is similar to the first study, but it's to predict the instance of opioid use disorder. And I want to quickly show this example is because, don't think about machine learning. The more complex one is better. Because in this example, in this study, you can see all the performance with four methods we use have a similar performance. But the ElasticNet, the one ElasticNet is more advanced of the lasso. It's only need 48 variables. So what I'm trying to say is that if all the methods are similar and you have one as we use the least of variable, you should choose that one because it will ease the clinical interpretation and the clinical operations. And I show you the 3 group, and this is we do the 10 group, and you can see the gradient going down. And so if use the top 2 data group in the risk score, you can see we can capture 70%. So I'm going to skip this because it's similar. And the other one is machine learning. I also use it to identify the medication adherence threshold and their risk of the hospitalization. So this is we think a lot of times you use the medication adherence cut point as 80%, either measured by the proportion of days covered. But we believe, patients have a different complexity and a different drug class and drug classes and subgroups. So 80% shouldn't uniformly apply to all the subgroups. So we use a retrospective study and identify the oral hypoglycemic medication and during the first year of the use, and to evaluate if any cut point differ by the subgroup, and see what this cut point is the most associated with all-cause hospitalization. And we use a random survival forest and survival tree. Tech AI is better. Okay, I'm going to talk about answer the question at the end just to save time. So there's important predictors, 8 important predictors identified, and the adherence is the 5th one identified as the important predictors. And as you can see, I know this looks scary, but it's just the orange bar is the medication adherence. And so interpreting the survival tree is like, okay, so this is a route. You have a total patient. If they don't have any prior hospitalization or ED visit, you go to this route. If they have insulin use, then they go to this route, greater than 90 days. If they have a monthly prescription greater than 13, you go to this route. And then you can see, or they don't have it, go to this route. And among the subgroup, the adherence threshold is a 59%. You need to have a 59% of the days covered in order to achieve the lower risk in this group. This is a hazard ratio. So I just want to give you an example of the application. So I want to use the last slide to talk about the challenge and direction in AI and machine learning. The problem, AI sounds promising. It's a great tool, great valuable solution in many cases. But one of you talking about the data security, yes, like a healthcare system, you all have a data privacy and a HIPAA confidentiality. So there's a challenge and there's also a lot of technique coming up, like a federal learning, try to resolve the security issues in the linkage in the different data. And we also need more methods and tools to integrate the multi-type of data, like lab result, imaging. There are different type of data. How do we integrate them together? And some of the machine learning are the black box, and how do we explain them and interpret the result, and how do we make them transparent enough and in terms to the clinical useful information, and how do you know, can you apply this rule you develop in Medicare in other settings? So we might have to use other transfer learning or different technique. And if your machine learning technique have some bias, racial bias, or racial not the equal unfairness, and you want to improve the equity situation, and how do you, there's a trustworthiness and accountability and legal issue we need to consider. So there are so many areas in the machine learning is waiting for you to work. So I want to say in summary, machine learning can help and contribute to tailor or personalized management or treatment that be more effective or efficient. I want to emphasize that it should be complementary to the traditional statistic analysis, not a replacement. And again, algorithms could be extremely complex and not easy to use, but it depends on your goal. And the prediction and the causation are not the same. And the balance, you need to balance between the complexity and the risk, benefit, and error. And it's better to engage the end user from the beginning of the study and to make sure the usability of your study. And you also need to encounter a lot of the implementation issue if you plan to carry forward. So thank you so much, and I want to thank you, my great research team, and especially Dr. Wally Gila from the University of Pittsburgh, and have given me a lot of great opportunity to work on this project. And I want to, now I'm happy to take any questions you have, and I want to say embrace yourself, and this is not online class is coming during the COVID season, but machine learning is coming. Thank you.
Thank you.
Sorry, I run over time.
Okay.
Yeah.
So thank you, Dr. Jenny, for explaining elaborately the artificial intelligence and machine learning on pharmaceutical outcomes and prediction and predictive analysis, which has direct effects on the personalized medicine for betterment of the healthcare. You have also you have explained very nicely that accuracy is more important than interpretability, right? Very important. And also, just I would like to trying to summarize your talk to the participants. Dr. Jenny also highlighted that she explained the identification and predictive analysis of high risk individual as well as high risk area, both, right, Jenny?
Right.
Yeah. And also she explained the types of prediction model studies covered by the tripod.
Yeah.
Tripod, yeah. And you have explained detailed research, which is really new to all of us who have pharmaceutical technology background, definitely, because as you are a pharmaceutical technologist, you have pharmacy background, but later on you did master degree in biostatistics. So so lot of knowledge you have gained from statistics and data handling. Then you did doctorate in epidemiology, pharmaceutical epidemiology. So I think your experience is much more better than common pharmacy people, which actually that is reflected by your research work, you know. Yeah, so you have explained detailed research work on the machine learning to predict risk factor of opioid overdose and use disorder, both.
Right.
And thank you, Jenny, for explaining the gaps in research and clinical practice. Yeah, a lot of gaps are there, which is really ignored during clinical practice. But there definitely the various gaps are there in research and direct clinical practice. And you have explained the research how to overcome the limitation of traditional statistical method, because a lot of limitations are there during research. People can see during the statistical method, but you have shown how to overcome it. Yeah. And also Dr. Jenny highlighted that the concept of prediction performance on by confusion metrics on opioid overdose, that is maybe true positive, false positive, even for non-opioid overdose for false negative, true negative.
Yeah.
all these in details. She did the research.
Yeah.
Also, she has explained how that machine learning research can influence the data on type 2 diabetes and type 1 diabetes, right, Jenny?
Yes, I kind of,
Yeah.
showed that, but I didn't explain too much. Yeah.
And totally, the two term that is really very new to us, definitely, that is the difference between the discrimination and calibration in concept review.
Yeah.
That's very
Yeah.
interesting. Yeah. That's
Yeah.
very interesting. And you have explained the outcomes of the pharmaceutical area under ROC curves, deep
Yeah.
learning, neural network, DNN, GBM, and
Yeah.
gradient boosting machine, EN
Yeah.
and RF, the four method, right?
Yeah.
And finally, you have also explained the positive alerts for next 3 months, that how the effect of overdose of opioids may have affect the particular people after 3 months. What will happen? That is the predictive
Yeah.
alerts to the people. Machine learning can
Yeah.
help, and
Yeah.
also for the risk stratification using DNN method,
Yeah.
right? So in case of also, you have explained this in same protocol and design is there for oral hypoglycemic agent OHA. Is it hypoglycemic or hyperglycemic, Jerry?
It's a oral hypoglycemic. It's like an oral medication for type 2 diabetes medication.
So for oral hypo or hyper? I think
Hypo, like a lower anti-diabetic medication.
Okay,
That's
okay.
another word. Yeah.
So OHA, right?
Yeah.
OHA.
Yeah.
Okay.
OHA. Yeah.
Yeah. So finally, so what's he explained that machine learning and artificial intelligence of pharmaceutical and health outcomes, there are a lot of challenges, but she has showed many directions by her research that that lot of problems like predictive analysis
Yeah.
of personalized medicine or tailored medicine, precise medicine for
Yeah.
opioid overdose or type 2 T2DM, T1DM patient. Many factors can be, can be decided before it happens to the patient.
Yes.
To avoid the side effect, to avoid the toxicity of the overdose, and definitely reduce the cost.
Right.
Okay, so it's a really excellent presentation, Jenny. Thank you so much. So let's start the question Q&A sessions. So should I pick up the question from chat box, Jenny?
So sure, we probably won't be able to go through all the questions, and I'm going to try to. Okay, scope of the student learning facility in machine learning. Also,
may I pick up the question, Jenny? May I help you to pick up the question? And
yeah. Thank you. Yeah.
Okay, so the first question is that
I think maybe.
and it's a question that is machine learning and artificial intelligence superior than QSR to predict the outcome? QSAR. Jenny, can you hear me?
Yeah. Which question you are reading? I didn't get it.
That is in 8:15 p.m. From anonymous attendee.
Oh, I think some of the question I already covered in my talk, so I don't think we can cover everything, and I think we already run out the time. So do you want to just pick up some like maybe one or two major questions? So in that way, we don't. I just want to be respectful for everybody's time.
Yes. Just pick up the representative question so that it cover all the questions. Okay.
Yeah, some of them I already cover. I mean, during my talk. So, which question? Can you repeat the question again?
So thank you, Professor Jenny, for such nice presentation. Is machine learning and AI superior than QSAR to predict the outcome? QSAR, quantitative structural activity relationship, that is for drug designing. That is a kind of predictive analysis. So which is superior?
Okay. Yeah, because that won't be my. I mean, the drug design. I'm more on the post marketing. So I think it's better to, pharmacovigilance. I mean, there's a different type of the different design. On the drug design, I think it's better for the drug discovery folk to answer that question, and I can answer better on the health outcome research one because I have more experience on that one. But it definitely can be used in that one. But the detailed technique in the drug discovery, I think it's better for drug discovery folk to answer that one. Yeah.
Okay, thank you. So another question from, I'm doing a PhD on ADR reporting and detection for drugs for diabetes and cardiovascular disease using prospective study. Can I improvise artificial learning, artificial intelligence and machine learning in my work?
Can the machine learning in what?
In diabetes, in detection of diabetes and cardiovascular disease.
Yeah, I mean, if you go to search on the article, some of the area has already been done. So, I mean, diabetes is a pretty hot topic, and I produced down a few. So some of the area, like, retinopathy, looking at Google doing the retinopathy on diabetes patient to screen who has a retinopathy, that's also been done. So you could find some topic, but make sure you really search the gap, in research and the science. And it's better to discuss with a clinician, see what kind of tool can better help you. And that's what better to identify if you want to study in the diabetes field or cardiovascular disease field.
Okay. And how fast can ML and AI help in clinical trials, and how can it benefit in silico methods? The last question.
Yeah, the clinical trial, that's a great question. Okay, so in the clinical trial, sometimes, for example, let me give you an example. I have another collaborator. They design a machine learning method to select. How do you know who you want to include in the clinical trial? Can you identify the patient? Sometimes you need to call them and then say, do you want to join the clinical trial or doing a poster? Which method is better? So sometimes you want to identify, the patient is the most tailored to your interest. And so they have a method to develop, which participants are more likely fit your study. And also, in terms of clinical trial, yes, clinical trial usually collects tons of data, like genomic data, survey data. Maybe if machine learning can help identify the important predictors instead of you just doing one by one. So that's a value in the machine learning too.
Okay, great. What is the difference between IoT, AI, and ML? What is the future importance and use of IoT in pharmaceutical industry?
The future importance and the use in the IoT. What is IoT?
Internet of Things.
Internet what?
Internet of Things.
Oh, well, I'm sorry. I think IoT is also part of AI, and a lot of times the terminology is changeably. So right. Sometimes it's a different technique, and you just using different terms. So I think, as I showed in the early on, these are all the very trending topic in the pharmaceutical company. And they also used to design a vaccine on different research and outcome and evaluate the value base. How do you make the drug pricing? So it's all in all the area, machine learning has been applied.
Okay.
And which language I learned from my work is pharmacovigilance. Pharmacovigilance is the type of the drug safety, and you try to detect the adverse outcome. So that's a spatial term. So, but sometimes we just use the drug safety, and you say the data mining in the adverse outcome. It's a similar concept, but it's a different terminology.
Another question from students: how can pharmacy students employ AI and ML in small effective projects as small step in the AI world?
How can a pharmacy student apply this? So my suggestion is that you don't have any analytical background, and you need to start. One thing you might feel interested is start with a visualization your data. And right now, there's a lot of free online tool. You can kind of visualize your data. That's the first starting point, because you need to understand your data. And once you visualize your data, you might find some interesting patterns. And then if you really want to do some application, you really need to have a data. But where is the data from? So you might want to find some free public available resource to download some data set you can use. And then there's some like a free resource like R or Python. There are a lot of the free online book resource you can go to see, or YouTube or Coursera. And if you want to apply those techniques, learn those techniques specifically, there might be somewhere to start. But it's a long trip. It's not an easy way. You are not going to learn machine learning AI application overnight. You know, it takes years of training and years of the experience.
Okay. So which one of the best programming language for AI? Is Python is best and easiest, or do you recommend another?
If you are the serious data analyst, Python probably is the most popular one being used, and some people use R. But if you have a really huge data, you are going to find Python might have more troubleshooting discussion helpful. So in our group, originally before we used R, then we start transfer to Python. So if you never learn anything, maybe start with Python might not be a bad idea. R and Python are both free.
Okay. Another question, how non-level data and interpret data act in machine learning as adapt process?
How long what? Excuse me?
How non-level data and interpret data act in machine learning as adapt process. You can find the question in the Prashanto Circle, 7:49 p.m. in QA box.
7:49. Oh, okay. Oh, okay. I just realized I was reading the wrong I was reading the chat box. I didn't know there's a Q&A session. Yeah.
Okay. Yeah. There is a QA session also. You can check the question. Okay.
Yeah. Oh, okay. I see. What time is it? The time you talk about?
7:45, I think.
7:45. Your time or my time?
Okay, that's a good question. This is my time, 7:45. So yours should be, I think, 10:15 morning.
10:15. Okay, sorry about that. Okay, non-labeled data. Okay.
$7.49 means 10.
Oh, how can pharmacy? As we know that every individual are different, is it possible to get an individualized solution for particular individual? Well, yeah, that's why one of the points we try to use machine learning to see if we can tailor the treatment. So when you get a rescore, each patient has each rescore. You probably can look at each pattern, but how detailed you want to go into the specialize your solution, it's also a question. You know, if you have a 100 different, you probably can do, you know, in the next few decades, maybe you can really develop some algorithm. Everybody's different, but how complicated you want to go, you also need to set up some threshold. So it's always a balance. It's never just being one-way solution, but there's also, you cannot also create like a 1,000 solution, right? And then you need to group in them. But what's your tolerance, you know? Yeah.
Okay. So do you think pharmacovigilance will get replaced by artificial intelligence someday, where different stages in the trials will not be required anymore?
Well, it is the, you know, the tree scan that I show you developed Harvard group. They use data mining technique to identify some potential adverse events or in a pharmacovigilance to identify potential safety signal. So it is happening, but they also use a lot of other techniques. So it's not just only AI and machine learning. So it is a different technique I'm applying. So it's going to be automatic for sure, But you say, are you going to replace doctor diagnosis or something? I think you still need some human component inside, because machine is still machine, but how can you turn it into your useful knowledge? It's need wisdom. And I don't think you can just totally rely on machine, because machine can make error too.
Yeah, yeah. Another question asked by a person that how about the rise of concern for data privacy and the implementation of artificial intelligence affect pharma's ability to collect or use data? She is asking about the data privacy. What about that?
Well, data privacy, that's a great question. So the data privacy is, like FDA has a Sentinel, US FDA created a Sentinel interface. So all the health plan can submit the data without compromise the prediction or compromise the work you want to do, and take out the PHI information and then aggregate in certain level. So there's a lot of the improvement in that area on the data security. And as I say, there's also federal learning, and it can be used in the using your data behind a firewall, and you can still achieve a certain improvement.
Thank you, Jenny. I think all questions over.
Yeah, thank you.
Thank you. Now I would like to thank Professor Purnabesh Chakraborty to be with us constantly. And I would like to thank Dr. Sandeep Bhattacharya for joining with us. And finally, I would like to thank Dr. Jenny Lo Sijani for giving us your valuable time from your busy schedule. Thank you, Jenny.
Thank you. Thank
your
you
presentation and research findings definitely benefited our participants. Thanks for joining with us. And I hope in future we will be connected with our university, because we are going to start a course on the artificial intelligence in pharmaceutical science, and we would like to get help from you, Jane. I would like to thank our participants to join with Makaut webinar, Department of Pharmaceutical Technology webinar. I hope the talk of Jerry has benefited you. And in future, we will make a community with Jenny and other scientists who are working on the AI and ML pharmaceutical science.
Thank you.
Hello, same Hussein sir.
Hello?
Yes sir, sir. Please sir, please tell. Hussein sir. Okay. For all the participants, this is the quiz link and
Hello?
feedback link. Yes sir,
Hello?
yes sir, sir. You were disconnected, sir.
Okay, okay, I'm sorry.
Yes
I'm
sir.
sorry. I was disconnected.
Sir, please continue, sir. Sir,
Okay,
your
where is
remarks.
Pranay, sir?
Sir, Praname, sir, I think disconnected, sir.
Oh,
So
already.
just now only disconnected. Yes.
And Dr. Jenny?
Yes, sir. Jenny ma'am also disconnected, sir.
So there is a problem in your link, I think.
Yes, sir. I think, sir, you were disconnected. After that, sir and ma'am left the session, sir.
Oh,
Yes, sir. Sir, if you give the permission, then we are sharing the links to the audience,
yes, please,
participants.
yes, please. Let me just.
Yes, sir, please. Secretary, please wait. Sir will give the permission to show.